which we have seen in the last month in our ward. She was a 58-year-old female from Chamoliana, Uttarakhand. She was admitted to our ward on 10th of August 2022. She was a housewife and history was taken by the patient and correlated with her son, and reliability was good. She presented with fever. It was high-grade intermittent fever for 20 days with chills and rigors, with no typical periodicity, and used to relieve with over-the-counter antipyretics. She also presented with painful reddish nodules over face and bilateral upper and lower limbs for 5 days, and it ulcerated within 2 days over the face and right lower limb. And she also had complaints of left eye pain associated with photophobia without any history of headache, blurring of vision or any loss of vision. In the past, she has complaints of numbness and tingling sensation in lower limbs, which started in the foot and gradually progressed up to the knee level without any history of slippage of slippers or any dragging of foot. And then similar complaints progressed to bilateral upper limbs over the month of 6 months. And she has history of hospitalization many times for swelling and ulceration of wounds over right lower limb. Recently in mid-July, she had a similar complaint of swelling followed by ulcer formation over right foot, for which she was admitted in our surgery department and wound care was given by the surgery department, and she was discharged at the end of the July. After discharge, she presented with these complaints after a week with fever, reddish nodules and left eye pain. In past history, she has no history of any hypertension, thyroid disorder, CAD, CVA and pulmonary tuberculosis. And in personal history, she doesn't have any history of TB or leprosy contact. There is no history of similar complaints in the family or in any neighborhood. She has history of hospitalization for right foot wounds, for which surgical care was given in many hospitals, and there is a doubtful history of diabetes mellitus told by the doctors but she doesn't remember any high sugar values or any documents available of high sugar values. On examination, she was conscious, oriented to time, place and person with full GCS of 15/15. Her BP was 110 by 80 mm of Hg, pulse was 74 per minute, respiratory rate was 16 per minute and temperature of 98 degree Fahrenheit. On GPE, she had pallor with no cyanosis, clubbing or palpable lymphadenopathy. She had pitting edema of bilateral feet up to mid-shin. In skin examination, she had multiple erythematous tender nodular lesion over face and bilateral upper and lower limbs with ulceration of nodules of face and right lower limb. I'll show the images. She has, in presentation, she had nodulo-ulcerative lesion over nose and nodulo-infiltrative lesion over face, and also some ulcer on palate. And similar lesion was found in bilateral upper and lower limbs with ulceration of nodules over lower limb, right foot. And in right lower limb, she had infected also over dorsum measuring 3 into 4 centimeters, and in plantar aspect measuring 10 into 6 centimeters from forefoot to midfoot area, associated with gangrene of right toe. This is the image of her ulcer. She had large ulcer measuring over 6 into 10 centimeter in the plantar aspect of the foot, and a similar ulcer over the dorsum aspect of the right foot with gangrene of the third toe. ENT examination had saddle nose deformity of nose with crusting. she had a saddle nose deformity with crusting of the nose. An ophthalmological examination was done by ophthalmology department, and she had left eye anterior cells with 4 plus and flare which is suggestive of acute anterior uveitis. In systemic examination, in CNS examination, her environmental function was intact. Cranial nerve examination, all cranial nerves were intact. In sensory system, she had sensory loss for pain, touch and temperature, completely lost in bilateral foot, 70% of the sensation intact in right lower, bilateral lower limb up to knee level and bilateral upper limb up to elbow level, and 50% of the sensation lost in bilateral palmar and dorsal aspect of the upper limb. And there is also palpable nerves in bilateral upper and lower limbs. Greater auricular nerve, ulnar nerve and peroneal nerve are palpable with grade 2. There is grading for palpable nerves. Grade 2 is moderate thickening of nerve which feels like rope-like sensation. In summary, in our patient, we have chronic symmetric distal sensory polyneuropathy with fever. In examination, erythema nodosum, saddle nose, and anterior uveitis and thicker nose. In background of this, our first differential diagnosis would be leprosy with erythema nodosum leprosum, and our far differential diagnosis will be vasculitis, which can explain our chronic symmetrical distal sensory polyneuropathy, fever, erythema nodosum, anterior uveitis, and saddle nose. In investigation, she had microcytic hypochromic anemia with neutrophilic leukocytosis and thrombocytosis. In liver function test, she had albuminoglobulin reversal and normal renal function test. Peripheral smear confirmed the same thing, microcytic hypochromic RBCs with neutrophilic leukocytosis with reticulocyte of 0.77%. Her inflammatory markers were raised, ferritin of 358.9 nanogram per ml and ESR of 105 millimeters per hour at first hour. And pus culture was sent from both nodular ulcerative lesion of face and right lower limb, which was sterile, and pulse culture and sensitivity from right foot lesion grew Proteus species and E. coli, which was sensitive to TG-site. Slit skin smear was done 2 times, which came out to be negative, and a skin biopsy was performed from lesion of bilateral upper limb, and the histopathological examination will be discussed by my colleague. And our blood glucose starting was done. Fasting blood glucose were within normal limits, and postprandial blood glucose were also within normal limits. We couldn't do HbA1c because HbA1c was not available in our hospital setting. Chest X-ray was done, which showed normal lung fields, cardiac silhouette, and mediastinal contour. And USG abdomen was done in previous surgery admission, which showed cholelithiasis, largest 16 mm with grade 1 fatty liver, but patient didn't have any symptoms. Bilateral lower limb Doppler was done, which didn't show any evidence of DVT, but had monophasic wave in right posterior tibial artery and dorsalis pedal artery. And X-ray of bilateral foot AP view showed osteolytic lesion in right foot. So we suspected patient could have osteomyelitis, and MRI right foot was done, which showed hyperintense signals in T288 images of right tarsal and metatarsal, and a sinus in the right plantar aspect, which was suggestive of osteomyelitis. So now my histopathological findings will be discussed by my colleague.
Before histopathology, we can have discussion.
Okay.
Comment or you can invite comment from the audience before we go to the histopathological diagnosis.
Any queries regarding the clinical presentation or any comments?
Is it so obvious that only just two differential diagnoses? I mean, there is no possibility of any other.
So to be frank enough, on the first
Yes, madam.
day,
No, no, I'm just asking the
You
audience.
finish,
I'm
you
just telling the
finish.
audience.
Okay, I thought you
I'm just telling the audience that
sure,
it
sure. So
means
they
that.
should respond. Actually, this is our case.
Yes, ma'am, please come.
I think a very interesting case, presented very well, but probably this diagnosis would have been made by the dermatology people at first, looking at all the. Anyway, the surprise feature will come from the histopathologist, from the pathologist. But I was looking at all the features and all. Diagnosis seems a little straightforward. Let's see. But so that's why we're presenting it at CPC, and a beautiful case with all the findings of the signs and symptoms, which have been very good for our undergraduates and even our postgraduates of medicine, but the audience is a little thin. Yeah, thank you. So no dermatology opinion was taken?
Dermatology opinion was taken.
Not mentioned, ma'am. We had consultation with dermatology who had suspected like two diseases like SLV and this leprosy. So we had leprosy.
So, good morning, respected Director Ma'am, Dean Ma'am, all the professionals here and the residents. So, I'm Dr. Samiksha Thapa from the Department of Pathology and pathological findings of these cases. So, before starting the microscopic findings, actually what happens, like they say the two different, two separate skin from the forearm, and each of them were measuring 0.3 by 0.2 into 0.1 centimeter. It was a very tiny skin biopsy. So this is the normal skin. So the normal skin consists of the three structures, as we know: epidermis, dermis, and the hypodermis.
Use pointer. Teachers.
I can use this portion. Okay. So these are the. So this is the epidermis. This portion is the dermis and the hypodermis. And the epidermis, we have a 4 strata or the 4 layers, except the acral regions of the skin, like the palm and the soles, which consist of another extra layers of stratum lucidum. And the dermis part is again divided into the two parts. The upper part is also known as the papillary dermis, because of the fact that because of the downward extension of the this epidermis, which is also called as a retiridis. So that form a kind of papillary-like projection. So it is called as a dermal papillary. And the collagen over here are very faint when we look at the histopathology. While the deep dermis is also called as the reticular dermis. Here more of the lymphatics, blood vessels, and the cutaneous admixtures are found. This portion is the hypodermis. It consists of the fibrous tissue and this fatty adipocytes tissue. Okay, so this consists of the normal tissue. The same thing. This from here to here, this is the epidermis, and the lower part is the dermis. Here you can appreciate these are the lightly stained collagen layer. So this is the upper dermis, and while there are the coarse and larger these collagen fibers, and this is the lower dermis. And this is the microscopic findings of the skin biopsy they have seen, and it is in 20s view. So here we can slightly appreciate some areas of inflammation over this dermal area and the lower dermal and few part of the subcutaneous tissue. So on commenting upon the epidermis, here we can see these are the keratin layers. So they have increased in number. So this is the hyperkeratotic lesion with this epidermis lined by the stratified squamous epithelium. In this picture we can see there in the basal layer this layer. We can see this is the black pigment here. These are the normal melanin. Okay, and this vacuolated area, there is a basal cell, vacuolation or degeneration is occurred, and it occurs because of the chronic lesion. And coming to this dermal part, this homogeneous pinkish normal collagen structure is there. This is called as a dentule, and it is found more in the lepromatous leprosy or in borderline lepromatous leprosy. And here these are the bluish area. What we see, what we appreciate here is these are the chronic inflammatory cells. They are the lymphocytes, and this few dot like structures with the abundant amount of foamy cytoplasm. These are the macrophages. So there is a lymphohistiocytic clusters over the dermal areas, and we can appreciate like this area. This area is the endothelial like small capillaries or vessels. And here are also some structures. These are the vascular area. So there is even a perivascular inflammatory infiltrates are also there. Yes, ma'am. No, die. So this is the upper dermis. Going down to deep dermis, as I have already mentioned, there are some cutaneous adhesion. Here we can appreciate these areas. They are forming a tubules like structures with the round nuclei. These are the cuboidal line epithelium. So they are the eccrine glands. So over the adnexal glands also you are seeing the dense inflammatory infiltrates. Okay. And here. So again the same thing. These are the eccrine glands. And the inflammatory cells are marked over here. And going down to the subcutaneous tissues, here we can see these are the fat lobules. These are the fatty lobules, and these are the septa. And here in septa, we can see the inflammatory infiltrates by the lymphocytes and few of the histiocytes. So it is called, whenever the inflammation is there in the subcutaneous tissue, it is called as a paniculitis. So more often here we can see the septal paniculitis is there. Since there is occurring in septa, and in some of the field this septa has been broadened because of the marked inflammatory infiltrate, thereby leading the corresponding decrease in the size of the normal adipocytes. Apart from that, here we can appreciate a very rich area there. No? This is the blood vessels. And so over the blood vessels also we can see the perivascular inflammatory infiltrate. So this chronic lymphohistiocytic clusters is intermixed with some of the neutrophils over here. And also this area, these cells are the neutrophil. So what happens now in ENL, in the early stage of ENL, there is a predominance of those neutrophils and the lymphocytes, but not the histiocytes. And in the second stage, what happens? These lymphocytes and lymphocytes and these neutrophils will decrease down, thereby occupying the more spaces by the histiocytes and some giant cells, and that may form like a granuloma. And in the advanced stage, what happens? These septas are there completely replaced by the fibrous tissues and lots of macrophages. So, in view of these findings, I think this is intermediate between the initial and the advanced stage of the ENL. So, if we diagnose correlating with the clinical findings of those ulnar nerve thickening without involvement of the CNS, and also the histopathological findings, one should suspect the case of leprosy, along with this paniculitis, which is paniculitis without vasculitis. So this suggests more towards the erythema leprosum. So for that, every cases we have to do the special staining for the leprobacillus, and we did the 5 farrow staining for that. And this was the overall, inflammatory area. So this is the Fadok staining. What is Fadok staining? It is just a modified Zetan staining that is particularly have more sensitive towards the Mycobacterium leprae. Okay, here we use special kind of this peanut well that will form a barrier in the thin wall of the lactobacilli, so that they can easily get washed by the alcohol or some. So use this. And here, though the clear-cut lactobacilli is not seen here. Here we can only just appreciate a very granular kind of material or a eosinophilic kind of pink material hue. So not in every lepromatous leprosy or in every leprosy what is clinically diagnosed can show the leprobacilli. So this might be the fragmented bacilli, or it can be the antigen of the bacteria. Okay, so this can be further, we do investigation like antimicrobacterial, immunocytochemical stain is there. That is called as the anti-BCC stain. So that can, somewhat prove this antigen and this fragmented bacilli. Apart from that, PCR test can be done. And even in the advanced stage of the lepromatous leprosy, one can do the sputum and this blood culture, because these bacilli are there inhaled by the alveolar macrophages and they are disseminated to the blood. So the sputum and the blood can be cultured. Can be tested. So apart from this, we did a Zetan staining as well. So obviously Zetan staining came out to be negative here. And so correlating in view of the clinical findings, this histopathological findings, we finally concluded our diagnosis as borderline lepromatous leprosy.